Hello everyone. Today we want to present about our product. Before that, we want to introduce ourselves. My name is Razan TID and my friend is.
And I'm Adam Ahmad.
What is a diabetes? Diabetes is a chronic disorder in metabolism of carbohydrate, protein, and fat due to absolute or relative deficiency of insulin secretion with or without varying degree of insulin resistance. According to the World Health Organization, the number of persons with type 2 diabetes mellitus in Indonesia would more than the triple by 2030, reaching 21.3 million people in the country. It's estimated that around 1.6 million people fatalities were directly attributable to GM in the same year, with another 2.2 million deaths being attributed to elevated blood glucose.
Okay, this is pathophysiology of diabetes mellitus type 2. There are major effect and minor effect. And this is for acarbosilan, glucose absorption will be decreased. For metformin, hepatic glucose output will be decreased. Sulfonylureas, insulin secretion will be increased. Ambiguanide will increase peripheral glucose uptake. Okay, this is a chart for insulin deficiency, and that includes glucagon excess. First, increased protein catabolism. This causes the muscles to shrivel. The shriveled muscles resulting in weight loss due to reduced number of calories in large quantities. Loss a lot of calories. And second, glucose uptake by cells decreases. This results in a deficiency of intracellular glucose, leading to lethargy and polyphagia due to the loss of many calories. However, this absorption can lead to hyperglycemia as well. The third, it's due to excess glucagon, which obviously increases its production from the liver. A rapid increase in glucagon will keep gluconeogenesis and gluconeogenesis uninhibited. This causes hyperglycemia. Hyperglycemia causes glycosuria, then osmotic diuresis, polyuria, and finally causes dehydration, so that increase the thirst, or we can call it polydipsia. In addition, hyperglycemia can also result in increased plasma osmolality, which stimulates hypothalamic osmoreceptors and results in thirst. Okay, so it can make you thirsty. On the glycosuria side, glycosuria can cause a lot of calorie loss, which can potentially lead to polyphagia and weight loss. The fourth one, the absorption of amino acids by cells decrease. This decrease causes an increase in amino acids in the plasma and may lead to gluconeogenesis. This gluconeogenesis triggers hyperglycemia. And the last one, lipolysis increases, which results in increased fatty acid in the blood, so that the production of acetyl-CoA produced triglycerides increases and results in hyperlipidemia. This is how glucose can affect triglyceride metabolism. Glucose enters the triglycerides pathway via fatty acids, which eventually produce triglycerides.
Here we can see the major complication of diabetes. The major complication of diabetes was divided into two types, microvascular and macrovascular. As for the microvascular, it will affect the eye, kidney, and neuropathy. High blood glucose and high blood pressure can damage the eye blood vessels, causing retinopathy, cataracts, and glaucoma. High blood pressure will damage the small blood vessels and will excess the blood glucose, and then will overwork the kidney, and it will result in neuropathy. And the hyperglycemia will damage the nerve in the peripheral nervous system, and these may result in pain and or numbness, so the feet wounds may go undetected and will get infected and lead into gangrene. Now the next one is macrovascular. It will affect brain, heart, and extremities. As for the brain, it will increase risks of stroke and cerebrovascular disease, including transient ischemic attack and cognitive impairment, etc. As for the heart, high blood pressure and insulin resistance will increase the risks of coronary heart disease. As for the extremities, peripheral vascular disease result from narrowing of blood vessels and increasing the risk of reduced or lack of blood flow in legs. The feet wounds are likely to heal slowly, and it will contributing to gangrene and other complications. Now, I will explain about alpha-glucosidase inhibitors. Alpha-glucosidase inhibitors work by inhibiting the action of alpha-glucosidase enzyme in the gastrointestinal tract, thus inhibiting glucose absorption in the small intestine. Alpha-glucosidase inhibitors should not be used in condition of severe liver failure and irritable bowel syndrome or IBS, because the possible side effects include bloating, accumulation of gas in the intestines, resulting in frequent flutters. Now we can go to the alpha-glucosidase inhibitor mechanism. Here, as we can see, the oligosaccharides will enter the intestinal brass border and will be digested by the alpha-glucosidase enzyme and will be converted into a glucose, which is a monosaccharide. To reduce side effects, small dose of drugs may be given initially. For example of this class of drugs are acarbose. Here we can see comparison of the oral antidiabetic agents. The first one is metformin. It will conserve the beta cell function, does not cause hypoglycemia, and will reduce the weight of the patient. And as for the maximum dosage, it was 3000 mg per day, and the frequency was twice a day or 3 times a day. And the creatinine cutoff was 1.8 mg per deciliter, and the liver safety is not safe and have a side effect which is gastrointestinal side effects, and the other side effects which is lactic acidosis. And now we can go to the next one. Glibenclamide will not conserve beta cell function and will cause hypoglycemia and does not reduce the weight of the patient. As for the maximum dosage for glibenclamide, it was 20 mg per day and will be consumed by the patient twice a day. The creatinine cutoff was 1.5 mg per deciliter, and the safety for the liver is not safe and have a side effect of prolonged hypoglycemia. Now, the next one is glipizide. It will not conserve beta cell function and will cause hypoglycemia and does not reduce the weight of the patient. As for the maximum dosage of glipizide, it was 20 mg per day and will be consumed by the patient twice a day. The creatinine cutoff was 2.5 mg per deciliter and it was not safe for the liver. And the side effect is weight gain and hypoglycemia. And then the next one is glycoside. It does not conserve the beta cell function and will cause hypoglycemia and does not reduce the weight of the patient. As for the maximum dosage for glycoside, it was 320 mg per day and will be consumed by the patient twice a day. The creatinine cutoff was 2.5 mg per deciliter and it was not safe for the liver and have the same side effect as glipizide, which is weight gain and hypoglycemia. The next one is glimepiride. It may conserve beta cell function or not and will cause hypoglycemia and does not reduce the weight of the patient. As for the maximum dosage for glimepiride, it was 8 mg per day and will be consumed by the patient in a frequency of once a day or twice a day. As for the creatinine cutoff for glimepiride, it was 1.7 mg per deciliter. And the same as the other, it was not safe for the liver. As for the side effects of glimepiride, it's the same as glipizide and glycoside, which is weight gain and hypoglycemia. The next one is pioglitazone. It will conserve beta cell function and does not cause hypoglycemia, but it will not reduce the weight of the patient. As for the maximum dosage of pioglitazone, it was 45 mg per day and will be consumed by the patient in a frequency of once a day. As for the creatinine cutoff, it was 4.5 mg per deciliter. And for the liver safety, it was not safe and have a side effect of edema. The next one is DPP-4 inhibitors. It will conserve the beta cell function and may cause hypoglycemia or not, and may reduce the weight of the patient or not. As for the maximum dosage of DPP-4 inhibitors, for the sitagliptin, it was 100 mg per day and will be consumed by the patient in a frequency of once a day. And for the creatinine cutoff, we need to decrease the dose of sitagliptin in renal failure. As for the liver safety, saxagliptin is relatively safe for the liver, and the side effect was gastrointestinal effect. As for the others, it was expensive, except for the tenagliptin.
According to Sarwono 2002, production of soybean in Indonesia was 0.8 million tons. It was enough only to meet 20% of the domestic needs. Meanwhile, 80% of the soybean needs was met by importing 3.2 million tons of soybean. Therefore, modification of the ingredients used for the producing tempe is one of the solutions to reduce the domestic needs for soybean. My previous research in 2019 showed the anti-diabetic effect of humitan tempeh powder of 50, 150, and 415 mg/kg reduced blood glucose levels by 121.8, 107.8, and 99.8 mg/kg respectively, compared to diabetes group 140.5 mg/kg. This study showed the mechanism of action of the bioactive compound from tempeh metan by in silico study. In silico docking study, the purpose is to predict the active constituent present in tempeh metan, which may be responsible for the anti-diabetic activity possessed by this plant. We screened all the compounds using a molecular vector Docker. Macromolecular structure of the receptor ligand was taken from the protein data bank. The docking is to obtain the MOLDOC score, re-rank score, and H-bond. 3D structure of all the molecules were prepared by using ChemDraw. 2 kmg crystalline structure was obtained from protein data bank. Ligands were imported to MPD and their energy were set to minimum possible. Solid surface of 2 kmg receptor protein was created and maximum of 5 different binding cavities were selected on it followed by its energy minimization. This is the picture of protein and ligand. A is a protein complex of 2 kmg with ligand. B is 2D, a carbo structure, and C is a native ligand in 3D. And this is a molecular docking analysis of compound from tempeh metan with 2 kmg protein. It was found that 4 compounds had an alpha-glucosidase inhibitory effect, namely verbascose, vitekin, cyanidin triglycoside, and chlorogenic acid. This is the result show that verbascose has interaction with amino acid. This is the result show that vitekin has interaction with amino acid. And this is the result show that cyanidin triglycoside has interaction with amino acid. This is the result show that chlorogenic acid has interaction with amino acid. So this is a 2D that A is isosteric interaction and hydrogen bond between amino acid and verbascose. B is vitekin. C is cyanidin triglycosidase. D is chlorogenic acid, and E is carbose. These molecules may be potential benefit in diabetes through their direct action on insulin receptor, but it needs to be further studied through in vitro and in vivo experimental before reaching any decisive conclusion. And the result obtained may be different if we use different software and different type of protein. The molecule was chosen because it has good accuracy and a cavity, so it is easier to know where the ligand interact with the receptor exactly. To conclude, tempeh metan has an anti-diabetic effect due to chemical ingredients such as verbascose, vitekin, cyanidin triglycosidase, chlorogenic acid, which is comparable to acarbose as an alpha-glucosidase inhibitor in silico study, and for further research is suggested to isolate the bioactive compound from tempeh metan, which act as an alpha-glucosidase inhibitor. So these are some awards of previous research of tempeh metan. First is gold medal in ISIF at Denpasar, Bali, silver medal in International Young Scientist Innovation Exhibition at Mandarin Court Hotel Kuala Lumpur, Malaysia, gold medal in Indonesia Invention and Innovation Promotion Association at Taman Mini Jakarta, special award from Malaysia in Indonesia Invention and Innovation Promotion Association at Taman Mini Jakarta, and finalist in Science Project Award at UNS Surakarta.
This is our team from Faculty of Medicine and Health
from University of Muhammadiyah Jakarta.
Thank you
Thank you
very
very
much.
much.